All right.
Hey everyone, this is the Nips and Sips podcast. Feature me, I'm Dr. Jeremy Boyd, and my partner in crime over there, Dr. Brandon Cruz. Today we're going to be talking about building off our last episode where we talked about my case report and combining joint mobilizations with neural dynamics or neural mobilizations. We're just going to talk about why we do it and what we see to make us want to do it, and a couple other things along the way. But before I get too much into it, Brandon, how's it going?
Going well, Jared. Thanks for the introduction. So you got the nice button-up shirt, looking sharp, man. I got
Sometimes.
today, I guess drink-wise today, I got my Buffalo Trace, which I forgot is actually pretty good. I like it a lot. So that's what I'm drinking. We had a great weekend with AOMT last week. I know you presented a couple times. I presented a few times here. Still a great weekend, though we weren't able to be in person and kind of just the intimacy and, being able to just geek out with like-minded people. That conference is amazing. If you're listening to this and you're a student, join it. It's like $15. It's well worth it. We have an EPSIG program too that is for early professionals. So if you're first couple years out and you're interested in orthopedics and manual therapy, highly advise you to check that out. It's basically mentors there to kind of help bounce ideas off of. I have no kickbacks or financial interest in that. I just think it's a great conference to attend. So definitely look into that. Jared, what you drinking and how was your poster presentation and everything? How'd that go?
Went well. I had a blast. It's been a while since I presented a poster. Not since I did CSM a couple years ago. But kind of lit the fire. I was like, I can try and make this a regular thing. But yeah, it went well. Had some good questions. The moderator loved the idea of the new technique, and I love the fact that it had the essence of fellowship and higher level training in that. You've kind of discussed with me in the past about combining, mobilizations, lumbar with some neural dynamics. And then what I got from a fellowship weekend 2 days beforehand about femoral nerve testing and bias testing a little bit of a different way. And then just combining the two, I think that really kind of captured the essence of the whole purpose of the conference. So I had a great time. It seemed like people enjoyed the case report. And but what I'm drinking is from my resident employee, Justin, who went to, I believe it was Delaware. He went to Rehoboth. And he said oddly around there.
Beach, yeah.
Yeah. He went a couple weekends ago and brought this back for me because he knows I'm a stout porterish kind of guy. It's a combination. We're going to be talking about combined mobilization. So figured, why not? It's called Glazed and Confused, which is a Boston cream donut stout. I love Boston cream donuts. So let's see how this puppy. Oh boy, bad opening here. We got
not a good start. Go ahead, man. Bring back the cows.
That is. Oh, this is sweet. Hold on.
Did they get you a 6-pack? You might have to say one for me because I love Boston cream donuts. And if I were to drink a beer, I do like the stouts.
Oh, all right. I'm gonna have to. He did just give one.
Justin, what are you doing, my man?
I'll have to send him back down. He seems like he goes to Delaware.
From where you are, it's probably only like an hour and a half drive or so.
Not bad at all. It is pretty sweet. So I'm gonna let my cup defizz here, but. That is a sweet, sweet stout. Let me give that one more sip there. It's getting better. It was very intense on the palate there for that first sip. I was like, I don't know if I'm going to get through this. I give it's definitely more of that sweeter than versus that darker kind of roastier stout. I'm going to give it a 7.6.
Ooh, low.
Yeah, low, more because the sweetness. It may increase as I go. The first sip was like, whew, I was going to start off real low. So then
10.
We're going to have to go down there and make a field trip. Let me see out of the cup. It's getting better, but let's stay 7.6. But
Jay,
Let's get
he's
into
talking
it.
shit. Other Jay, he's talking shit on the beer you got him. I don't know. I
He's
want a
never gonna
beer.
give me another beer ever again. Uh, Apparently,
Okay.
that's a thing down there. Is they combine donuts a lot with their beers down in Delaware. Apparently, so yeah, I was like, yeah,
All
I'm more of
right.
a tradition also.
Let's kind of go and get into the show here.
Yeah,
Yeah, last week, if you haven't checked out that episode yet, Jeremy presented his case for our audience here on the podcast, and just an insight into his thinking, really thinking outside the box, some novel techniques. Maybe research hasn't caught up to some stuff yet. Actually, and there are some articles, but they're so new we can't get access to them yet.
hmm
We've tried to pull them up, but it's really just about thinking outside the box. Can you take some of your reasoning and clinical decision making to the next step, and combine two or three different interventions from there? So, Jay, let's I guess take us out there with some of the combined mobilizations and neurodynamics that we can do.
yeah. I want to just also kind of throw in, as you mentioned, it was like some articles are so new, or we quite haven't understood. I saw a good quote. I don't know if it's Twitter, I can't remember, but someone wrote in the because a lot of things are always pitted against placebo. And someone pointed it was like placebo effect is something that the Western medicine or Western society hasn't quite just embraced yet. I think a lot of it's just quite hasn't understood yet. So we always like, oh well, it's placebo, but which is still a positive effect for some of our techniques and those sort of things. But maybe there is something is truly happening versus just the mind is thinking and we just don't understand it yet.
Yeah,
So I thought that was a good quote based off of
great quote.
what you're saying. But yeah, in talking about combined techniques and neural mobilizations. I guess my journey started in residency, where we talked about cervical techniques with um, typically median or upper limb tension test A, radial ulnar glides. Wasn't too much talked about with the lumbar spine and those sort of things. And yeah, I remember prior to that it was like two separate things. It was like, oh, patients got some neck stiffnesses or hypomobilities, whatever you want to call it, and then they got upper limb tension. It'd always be like do one then the other, one and then the other.
Yep.
And then especially with nerves and how they can be very kind of touch and go-y. um, bring it up where combining the techniques, especially using it as a test. It's not a formal special test that we learn about in PT school, but combining a technique. And I'll talk about the ones that I learned or initiated first was just a lateral glide. Sorry, I can't do it. Not so much a side bend, but a lateral glide towards would kind of gap and open up things. That's why I kind of started off with. I put up Christo Savo's study about doing cervical distraction. And then testing out upper limb tension tests. So now I'll like do upper limb tension tests, see where they get to that point at each joint of where they can go for before symptoms are elicited. And now I'll just maybe do a lateral glide and see if they can get further. Now I've kind of taken it even more of an approach of I'll look at a lateral glide. I'll look at just a pure joint distraction technique. Doing a combined opening, which is flexion, opposite rotation, side bend, just to really open up that side and then retest. And then in my fellowship training from IAR, they discussed doing an actual posterior glide of the level, which is not very fun at the cervical spine. You have to get in there, try and push things away. Obviously, you're pushing on multiple things, but you do kind of feel that cervical spine. And I've had some positive results of doing that and then trying to do a neural mobilization. So that's just the cervical spine. We'll start maybe talking off those sort of things, but yeah, use it first as a test. And if you can buy someone just a couple more degrees of range of motion or centimeters and those sort of things of less painful, irritated nerve movement, that can be a game changer for a lot of these individuals. So first use it as a test, and right there and then I find, oh, this is the winner one. When I first started, it was like one technique and combined. Now it's like 4 or 5. And then right there and then I'm like, all right, let me just play around there for a couple minutes and then reassess without anything. And all of a sudden they're more lengthened up. But yeah, what about you, Brandon? Well, I guess I kind of got on the roll with the cervical spine.
Yeah,
But
yeah, all good, and that's kind of where a lot of this stuff started. I mean, the studies that at least are out there are geared around the cervical spine. You know, we talk about some of the knee articles, and that's where it started, and that's what you were referring to when we learned about it in residency. And there just haven't been other studies to follow it up for different regions, but doesn't mean we can't take that concept and begin to apply it. I believe we talked about that last week. And actually, currently, I'm mentoring a fellow in training, and I actually have 2 students with me as well, DPT students. So we're having these conversations more often. Actually, last night we were talking about just nerve glides and or neurodynamics in general. And I think in entry-level PT school, for whatever reason, you know, nerves are kind of glossed over. It's like, yeah, and there's this, and maybe they touch upon it real quick, and that is it. And I get it; they have a lot of other things, and maybe the art of feeling out and treating neurodynamics is not what they need to spend the time on. But you know, those PTs who think that they have enough or are experts after they come out at the entry level training, I mean, you're missing a lot. You know, it's not to shun you, but you know, I see and hear a lot out there from other thought leaders in our profession, Instagram gurus and stuff like that. That, you know, they're saying you don't need advanced training and you don't need mentorship and this, that you have enough and you just need to work. And while that's true, you know, you do need to work and get experience. You need something to hone your thought process and to show you these outside the box things, so you can evolve and get better. And obviously that's why we started this podcast, to kind of spread a hopefully a better message. But I've kind of digressed off my point. Going back to neurodynamics, you know, it's taught mainly as a test. It's taught, you know, if it recreates numbness or tingling, you know, or if somebody has a radiculopathy, upper or lower extremity, you know, perform this test and then treat it. But what does that treatment actually look like? And maybe some programs talk about flossing versus gliding, or tensioning versus sliding. But can we take that to the next step? Can you develop your feel over time? And that feel is, you know, if you do a neurodynamic and maybe they don't recreate numbness and tingling, but is it tight? Can they only get to here and then things start to feel like they're pulling? Or when you perform this, does your shoulder automatically shrug up? Those are all indications that things aren't gliding, or there's not that elasticity or mobility within the nerve that you need. And Jared, I believe this is from your program. I'm just going to share this photo here. Conceptually, what's going on? Hold on one second here. You know, we have the nerve as the green line here. We have a joint, looks like a, let's say, elbow joint. And as you bend, we're causing some increased tension and tautness through that nerve. And that nerve needs to have the ability, that variability, to be able to glide and move. So we need to be able to spend 10, 15 reps to see if things open up. You know, those 10 or 15 reps are really only 15, 20 seconds, 30 seconds of evaluation / treatment time. And this is what we talk about a lot: utilizing your evaluation and which becomes your treatment, and your treatment then in turn becomes your assessment and evaluation as well. Because if you do 10 or 15 and things begin to open up and relax, okay, I know I'm on the right track, and then you retest an asterisk sign. So I think before we start really talking about, you know, jump in and do a distraction technique or a side glide technique, having that concept and understanding of, you know, the principles of neurodynamics and what the nerves like, right? They like space, they like air, they like motion. We also have to include the biochemical side of things, blood flow, and the other biochemicals that are being, I guess, elicited or changing or have an effect with that. And that's just from that standpoint, let alone, can we alter, sensitivity, right?
Mm-hmm.
People who have pain or, allodynia or crips or some type of sensitivity where they don't like being touched, tender to palpation, like a jump sign, right? What controls pain? What controls, sensory nerve endings? It's or sensory pain.
System.
It's the nervous system. Like,
Mm-hmm.
why is
They run the
that
show.
pushed down so far below in our treatment philosophy? We also, think about a hypertonic muscle. What controls the muscle? Again, it's the proprioceptives and the nervous system, and that nervous system then goes into the brain. So that's our backdoor way into the brain. All these people, I want to talk pain science. And I think we've talked about neurodynamics before, but it's good
Of course.
to always kind of circle back with that, and then begin to now incorporate it. Okay, have that mindset, and now, like Jeremy said, incorporate nerve glides, side glides of the cervical
Mm-hmm.
spine, combine motions of side bending and rotation, even something like a anterior to posterior. And maybe that's not something you do regularly, but at least you're aware of it. If you're not aware of it, and that's something Kyle always says, if you're not aware of it, how do you know, how do you have the cognizant or the presence of mind to then even try it or think about it? So I think, that was my little rant on that.
They brought up some great points. Yeah, especially with the thing what you say about schools and those sort of things. And, um, you know, actually my school, I'll give my school that they did present some neural dynamics. I don't know if you've ever had the pleasure of meeting Mark Butler. He's in the
I have not,
NovaCare system.
but I've heard about him. I heard he's a
Yeah, he's done a
neurosurgeon.
lot.
Yeah.
Yeah, he's done a lot of like trying to test and trying to make objective measures through it. This is kind of a step-by-step process. I got a lot of that. I know at the time when I was graduating and even that residency, the understanding of neural dynamics and how it was presented, and especially our clinical practice guidelines, usually received a lower grade. Um, and then I kind of, I guess, probably took that probably too much to heart and was like, hey, all right, I'm not going to go crazy with this sort of stuff. And which was a shame for all those patients that I did, because then I started to like look into it more and more and more, and starting to, I think my testing just sucked. I just, I just didn't quite grab how to do it in a step by step. I just put them in and I'm like, all right, let's go. How's it? So, okay, it's the other side. Or I didn't look at, the compensations or at what level. And wasn't, systematic on both sides, or like different slightly both sides. So I guess kind of didn't do so much of it. And then just really kind of spend more time with my clients, listening to them. It sounded like something neural related. And just being very, very picky on how I test, the more and more it came about. And now I use it every single day, and these patients are all, getting remarkably better. So, yeah, definitely something, if you don't have any understanding of or those sort of things, definitely look into it. I would say, I see a lot of people from a lot of other healthcare practitioners, people have been to PT before. That's something that's commonly missed. Yes, movement's going to get the nerves moving, but let's face it, we have to bias them and give them their specific, tender love and care. And I think, doing neural dynamics and addressing that, calming it down, getting them moving in their specific sheaths can do that. And you mentioned a great point of, there's like air, they like to move, they like their space, they like blood flow. When you're doing something like a combined technique, you're getting the neurophysiological effects of the joint mobilizations because you're moving the mechanoreceptors and everything like that. Descending inhibition at the local level. And now you're moving the nerve. So now the nerve is moving back and forth, whether you floss it or glide it. And now, especially if you're combining with the active approach as the patient's moving it, we're now making the patient actively do something. You're getting a neurophysiological effect from the joint mobs, and you're also probably educating it one time. So you're getting a lot all at once. And that's why I feel like it's a very effective treatment, especially for these individuals with chronic radicular pain. So just brought up some points I wanted to kind of hammer it home there,
All great,
Brandon.
all great stuff. While
Very good now.
we're talking about neural dynamics with mobilizations, and yeah, obviously you can do it of the C spine, the T spine, the lumbar spine, right? P to A of the lumbar spine while the person's leg hanging off the table in a straight leg raise. You can have them in a sideline position and begin to gap them in a lumbopelvic region and still have them in a straight leg raise motion, or even if you have a second therapist, bring them back into something like you were doing with the femoral or obturator nerve last week. Um, but thinking even a different variation, can we do nerve glides with load to it? Can we do it weight bearing? When I do neurodynamics of, let's say, the median nerve, if they're not irritable or less irritable, I'm adding pressure. I'm adding load into depression of the shoulder blade or at the elbow joint or at the fingers, and adding some increased load. Those chronic people, those athletes, those weightlifters that we tend to see, they have, maybe their pain comes on, in their 60th rep or 50th rep, or, a runner, their pain may come on mile 12. Well, we need to, think about the repetitive nature and repetitive of loading of those things, and how can we create that in the clinic? Perhaps weight bearing. There are times I'll get somebody in like a half kneeling position and put their arm down, in a neurodynamic bias, and have them mobilize their T-spine or neck or something else. So now we're getting some weight and load through that extremity. Even things like an RDL, or using some banded mobilizations, like some, weight bearing nerve flossing and things like that. So we're mobilizing the hip with a super band as the person gets a sciatic nerve floss in weight bearing, or a half kneeling position where you're, what would be thought to be a rec fem quad stretch. Can we add a lateral glide or an anterior glide with a super band and shift their weight laterally, so we're getting that lateral cutaneous femoral nerve in a weight bearing position that the patient can also do by themselves. Like, this is kind of that higher level, next level thinking, and that outside the box thinking. That all things that you can do with neurodynamics that can all then become self or home exercise programs, and really kind of clean up some things, especially those patients that you're getting better, but not quite good enough.
Mm-hmm.
So,
yeah. So speaking of higher level things, Steve Kinney went to your fellowship. He also presented during AOMT, and he did his neural dynamics to bias kind of what the athlete did, which was I believe a martial arts. Pretty sure it's martial arts.
Martial arts.
It's crescent kick. Yep. Yeah. So he started looking in and started tying into that. It's a great presentation. He also had asterisk sign of an 8-hour car ride, but you can see, as how he started and what he was looking at was a slump test with upper limb tension test. So he's combining now upper and lower. Again, it's one involved system, connected top to bottom. And now he's also looking at the pain with a crescent kick, which is what the athlete was doing, and then he's modifying his neural dynamic techniques to start to bias the athlete itself as you start to look down and the patient's kind of in that split position. So there's just some really high level thinking with that. I saw this, I was like, that's some cool shit. I don't know if I would have felt to kind of even get into that, into those positions for that client, but he made some great progress. I think the patient was seen 4 or 5 times, 6 times. I can't remember.
I zoomed in. 4 session, which was the last session. Yeah. 4 sessions he got him put. Yeah. Steve Kinney's great. Bright guy, man. Really, really smart. Dedicated to what he does. To talk about that 8-hour car ride. I mean, look at that middle picture. That's basically one arm on the wheel and that left foot on the gas pedal. That's tractioning. You're putting tension through that nervous system driving. And if someone who has pain driving and can't sit in a car for a while because things flare up, well, how about we test out some neurodynamics and some combined positions, as you were saying, to clear some stuff up. So he had two things he cleared up, and let's see if we go lower. The crescent kick, which is a higher level thing, but something as low as sitting in a car. So, kudos to Steve Kinney. Shout out to him and his progress in the program. We're going to get him on the show for you guys, either to present with this or kind of talk about some of his other topics he's passionate about. But that'll be this is a great case that we wanted to share with everybody.
Yeah.
Anything else, Jared? I think that was pretty much it.
That's pretty good, yeah. And that's the main theme is test it out. Again, as in you see with what Steve's done, what Brandon has discussed, what my case study. Again, it was these things haven't been out in the literature. I don't think there's ever been anything that like what Steve showed here. Maybe someone else has and just hasn't presented to the research, but you have to have that degree of creativity, but understanding the foundations of why it could potentially work. And it may not. And then that's when you go back to the drawing board. But if you're not doing it, you'll never know. So definitely, look into this sort of stuff as a 7-year clinician who's constantly looking to improve things quicker and faster and, build up my own reputation and brand. Adding these sort of things in have really, changed things and been a game changer in my overall career and just, effectiveness. So definitely take a look at all this sort of stuff. That's my last thing there.
Awesome. Thanks, Jared. Great wrap up there. Well said. Let's close this out. We'll kind of make our final announcements here, guys. We have our spinal manip course coming up December 5th and 6th in Verona, New Jersey at my office, Pursuit PT. Seats are running out quick. We have about 4 left. So if you haven't signed up and if you're in the area, please take it or sign up. We also have our manual therapy mentorship program, which is kind of rocking and rolling at this point. Get access to 3 fellows. We're accessible via, private Facebook chats. We have bi-monthly calls, access to 600 articles, over 120 videos that we keep updating with step-by-step instruction on manual techniques. So if you're really trying to take your decision-making, your clinical skills to the next level, even business skills, we have a business section on there, being that all 3 of us are business owners. It's a great resource for you guys. Only $30 a month, cancel anytime. So feel free to do that. We have our video series videos that you can purchase as well, a la carte, so separate of the manual therapy. So if you just want to get those videos and techniques and practice them and have them on hand, we created an app where you can easily download it and keep it on your phone and access it during the day. So that's what's kind of going on that front. Am I missing anything, Jared? I think that's
well done. Yeah, if you have any questions or anything like that, comments or anything, just feel free to reach out to us. We love it. Feel free to subscribe to us, and then we always appreciate some reviews and feedback on Apple. I think that's the main one, but any sort of things that you may find. So like us and all that. And yeah, thanks for tuning in. If you want to reach out to us, we're at Manips and Sips on Facebook, Instagram, and Twitter. I'm at The Decent Doctor and at Trifecta Therapeutics. Brandon's at Think Like a Fellow and at Pursue PT now. But yeah, thanks for listening in, and cheers, everyone. I got a lot of beer to drink, so.
You guys, last announcement: we're on YouTube, so our videos are now on YouTube. If you want to see the articles or just see our lovely faces and watching us drink and argue and banter, we're on YouTube. So there you go.
There we go. All right. See you guys soon.